1, 2,
And maybe 70-year-old female
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Usually when we talk about a medical diagnosis, there's this expectation of precision. It's almost like engineering.
Right, yeah.
You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is.
Exactly. It's binary, broken or not broken.
Yeah, it's clean. But then you step into the world of acute psychiatric emergencies, and suddenly that x-ray machine is entirely useless.
Totally useless.
We are looking at a diagnostic landscape that is, well, honestly, it's murky. You're dealing with behavior, with altered realities, with brains that are, kind of betraying their owners.
It is the absolute definition of diagnostic muddy waters. And because the landscape is so complex, the tools we use to navigate it, the medications we give, well, they have to be incredibly powerful.
Right.
Which also means they demand absolute respect and a really deep mechanistic understanding from anyone administering them.
Which brings us to today. Welcome to a very special, highly focused clinical deep dive. Today, we are stepping into the shoes of an elite clinical pharmacist and an expert nursing instructor. And we are doing this just for you, whether you are prepping for the NCLEX, getting ready for a clinical shift, or you just have an insatiable curiosity about how one of the most heavy-hitting medications in the hospital actually rewires the brain.
Our mission today is really all about applying the Pareto principle to a legendary drug. I'm talking about haloperidol, which is almost universally known by its brand name, Haldol.
The Pareto principle. So the idea that 20% of the information will give you 80% of the understanding.
Exactly.
We are extracting the exact 20% of clinical gold you need to master this medication. We're going to deconstruct this drug completely. Not just what it does, but, why it does it.
Right. We'll look at how it physically alters brain chemistry, the traps to avoid when getting it into a patient's body, and how to spot the red flags when things go wrong.
To start, we really have to establish its identity. What are we looking at here?
So haloperidol is a first-generation antipsychotic. You might also hear it referred to as a conventional or typical antipsychotic.
Okay.
More specifically, it is a high-potency conventional antipsychotic, and it's structurally related to another major drug called droperidol.
High potency. That is a key word I want to flag right away.
Yeah.
But let's get into the engine room here. Let's talk about the mechanism of action.
Yeah, let's do it.
How does a high-potency drug like Haldol actually pull someone out of a severe psychotic break?
It all comes down to one primary neurotransmitter, and that's dopamine. Haloperidol fundamentally works by blocking central postsynaptic dopamine receptors.
Specifically the D2 receptors, right?
Exactly, the D2 receptors. And it targets these in a very specific part of the brain called the mesolimbic pathway.
Okay, let's unpack that, because the mesolimbic pathway is, well, it's essentially the brain's reward and emotion center.
Right.
So think of dopamine there as a really loud stereo system. In conditions like schizophrenia or during an acute psychotic break, that stereo is just cranked all the way up.
It's deafening.
Yeah. The brain is flooded with dopamine, and that overload causes hallucinations and delusions. So Haldol acts as the volume knob that just firmly turns that stereo down.
That is exactly what gives us the therapeutic effect we want. We know the medication is working when we see a decrease in the positive symptoms of schizophrenia.
And we should clarify, positive in psychiatry doesn't mean good.
Right. It means something is being added to the patient's reality that shouldn't be there.
Like auditory hallucinations, paranoid delusions, or, severe acute agitation.
Spot on. But here is the critical physiological catch. Haldol isn't a smart bomb. It's a volume knob, but it's wired to several different speakers throughout the house.
Oh, I see.
Yeah, dopamine exists in multiple pathways in the brain, and it's doing entirely different jobs in each one.
Which is where the danger comes in. Because if I remember my neuroanatomy, what happens when Haldol accidentally turns down the dopamine volume in the nigrostriatal pathway?
That's the big question.
Because that's the area that controls our smooth muscle movements, right?
Exactly. The nigrostriatal pathway is basically the conductor of your muscles. Its normal day job is ensuring your movements are fluid and coordinated.
Okay.
So when Haldol blocks dopamine there, the conductor drops the baton. The patient experiences extrapyramidal symptoms, which they look remarkably like Parkinson's disease. Tremors, stiffness, shuffling.
Wow. And then there's the tuberoinfundibular tract.
Right. That pathway regulates the pituitary gland and hormones.
Huh.
If you block dopamine there, it acts like a switch that suddenly tells the body to release a hormone called prolactin.
So that leads to side effects you wouldn't typically associate with a psychiatric drug, right? Like weight gain, menstrual irregularities, or galactorrhea, which is spontaneous milk production.
Exactly. It is wild how blocking one chemical causes everything from muscle tremors to hormonal shifts, all just based on the zip code in the brain.
It really is. But I noticed in the sources that Haldol has a very weak affinity for other types of receptors, specifically muscarinic alpha-1 and H1 receptors.
Yeah.
Why does that matter clinically?
Well, it matters immensely because it makes Haldol somewhat cleaner in specific ways compared to older, lower potency antipsychotics like chlorpromazine.
Cleaner how?
Because it doesn't aggressively block H1 or histamine receptors, it's less likely to cause that severe knockout sedation.
Oh, okay.
And because it ignores alpha-1 receptors, it's less likely to cause massive orthostatic hypotension, that dizzy bottoming out of blood pressure when you stand up.
Right. And the weak muscarinic affinity.
That means far fewer anticholinergic effects like massive urinary retention or severely blurred vision.
Okay, so it is highly targeted at dopamine.
Yeah.
So if this drug acts as this powerful targeted volume knob for dopamine, in what scenarios are we actually reaching for it in the automated dispensing cabinet?
The FDA-approved priority uses are pretty straightforward. It's frontline for the treatment of schizophrenia.
Okay.
It's also used for Tourette's disorder, specifically to control those severe octrisics and vocal utterances by quieting the motor pathways.
Makes sense.
It's also approved for severe behavioral problems or ADHD in children who show excessive, uncontrollable motor activity with conduct disorders. And of course, it is a massive player in the hospital for acute agitation.
But in the clinical setting, we see drugs used off-label constantly.
We do, yeah. And Haldol is absolutely no exception. It is heavily relied upon in the intensive care unit for treating severe delirium in both adults and pediatric patients.
Right.
We also see it used for the severe behavioral and psychological symptoms of dementia, often abbreviated as BPSD. It is even used sometimes as a second-line rescue treatment for chemotherapy-induced nausea and vomiting.
Although the guidelines heavily prefer olanzapine for the chemonausea now. But I was looking through the off-label uses in our sources, and I spotted a highly unusual one. I actually have to push back on this because it sounds like a typo.
Oh, I know what you're going to say.
Intractable hiccups. We're giving a heavy-duty, high-potency antipsychotic for hiccups.
It sounds totally absurd until you look at the mechanism. 2 to 5 milligrams of Haldol given intramuscularly is remarkably effective for persistent syngultus, which is the medical term for intractable hiccups.
But how? What does dopamine have to do with my diaphragm spasming?
Well, a hiccup is essentially a misfiring reflex arc in the brainstem and the vagus nerve. Dopamine plays a role in modulating that reflex arc.
Oh, interesting.
Yeah, so by blocking it, you can essentially reset the circuit. Now, why Haldol specifically over other drugs? It goes right back to what we just discussed about its receptor profile.
The weak alpha-1 affinity.
Exactly. Haldol produces much less hypotension than alternatives like chlorpromazine. If you have an elderly patient who hasn't slept in 3 days because of hiccups, you want to stop the reflex arc without accidentally tanking their blood pressure when they try to walk to the bathroom.
That makes so much sense when you connect the receptor profile to the clinical decision. It's not just about what works, it's about what works safely.
Exactly.
Which leads us perfectly into how we actually get this drug into the body, because picking the right indication is only half the battle. How a nurse administers Haldol can literally make or break patient safety, especially given how it's metabolized.
Yeah, pharmacokinetics is where things get really fascinating. Haloperidol undergoes extensive first-pass metabolism in the liver.
Okay.
The 2 primary hepatic enzymes responsible for breaking it down are CYP2D6 and CYP3A4.
And the sources explicitly note that some people are genetic, slow metabolizers of CYP2D6.
Yes, and if you are at the bedside, that is a massive safety consideration.
Why is that?
Well, if a patient is a slow metabolizer, their liver enzymes are sluggish. The drug isn't cleared efficiently, meaning it just builds up in their bloodstream.
Oh, wow.
So these patients are at a significantly higher risk for experiencing those extrapyramidal symptoms, the Parkinson's-like movements, because they have a much higher concentration of dopamine blockade happening than you intended.
It's like giving them a double dose without knowing it.
Pretty much.
So the half-life for the immediate release formulation averages around 16 hours. But the formulations themselves are where we really need to focus, because this is where the medication errors happen. Let's talk about the oral concentrate solution first.
Okay, for the oral liquid, you can administer it directly or you can mix it with food or a beverage to minimize gastrointestinal irritation.
Right.
But there is a massive absolute exception. You never mix the liquid concentrate with coffee or tea.
Yeah, I looked into exactly why this happens, because don't mix with tea sounds like, a weird superstition.
It does.
But it's pure chemistry. Coffee and tea contain high levels of tannins. When tannins interact with the chemical structure of haloperidol, they bind together and create an insoluble precipitate.
Yeah.
The drug essentially turns into a solid, useless clump at the bottom of the cup, so the patient gets zero medication.
Exactly. It's a chemical deactivation. And while we are talking about the liquid formulation, there's another crucial nursing intervention. You have to avoid skin contact during administration.
Oh, right.
If the concentrate repeatedly gets on your hands, it can cause severe contact dermatitis.
Good to know. But let's move to the injectables, because this is the classic test trap in a real-world safety crisis.
Oh, absolutely.
There are two intramuscular forms. There's haloperidol lactate and haloperidol decanoate. If I'm a tired nurse on a night shift, I need to know the crystal clear distinction between these two, because mixing them up is incredibly dangerous.
Okay, here is the rule to live by. Haloperidol lactate is immediate release. Think lactate equals light speed.
Lactate equals light speed. Got it.
It works quickly, typically within 20 to 30 minutes, and the maximum IM dose for adults is 20 milligrams per day.
Okay.
Haloperidol decanoate, on the other hand, is a depot injection. It's designed for prolonged therapy, usually for outpatients who struggle with daily medication adherence.
And the key to understanding why it's prolonged is in how it's made, right? The decanoate formulation is dissolved in sesame oil.
Yes.
So when you inject that into a muscle, you're putting a pocket of heavy oil into an aqueous, watery environment.
And oil and water don't mix.
Exactly. They don't mix easily. So the body can only absorb the drug incredibly slowly from the edges of that oil depot over weeks.
That is the perfect way to visualize it. Because of that oil depot mechanism, decanoate takes about 6 days just to reach its peak concentration.
6 days. Wow.
Yeah. And its half-life stretches out to around 3 weeks. And because it is thick oil, decanoate must be given deep intramuscularly only. You never give it IV.
Never, Bar.
Use a 21-gauge needle, and you never exceed 3 milliliters per injection site, or you risk severe tissue irritation.
Okay, so lactate is aqueous and immediate. Decanoate is oil-based, delayed, depot, and deep IM only. But what about giving it intravenously?
This is where the clinical tension really ratchets up. Intravenous administration of haloperidol lactate is not FDA approved for any population.
Wait, really? Not at all?
Not on the label. However, it is frequently used off-label in ICUs to manage severe delirium.
Okay, but if the FDA hasn't approved it for an IV line, why are intensivists ordering it, and what exactly is the risk?
Well, they order it because in a critically ill, highly agitated patient, like someone trying to rip out their breathing tube, you need rapid, predictable onset. You can't wait 30 minutes for an IM shot to absorb.
That makes sense.
But the catch is a severe, potentially lethal risk to the heart. Intravenous administration, especially at higher doses, is strongly associated with QT prolongation.
And just to clarify the physiology there, the QT interval on an ECG represents the time it takes for the heart's ventricles to recharge or repolarize for the next beat.
Right.
So Haldol basically stretches that recharge time out.
Precisely. And if you stretch that recharge time out too far, the heart's electrical system can misfire into a lethal, chaotic arrhythmia called torsade de pointe.
Oh, wow.
Because of this, if you are administering it IV off-label, it must be a slow IV push or infusion over several minutes, and continuous ECG monitoring is an absolute non-negotiable necessity.
And beyond watching the heart monitor, you also have to watch the lab values, right? Specifically sodium.
Yes, absolutely.
Because Haldol has the potential to induce hyponatremia and SIADH, which is the syndrome of inappropriate antidiuretic hormone.
Yeah.
Basically, the body holds on to too much water, which dilutes the sodium in the blood.
So you've safely administered the medication, you didn't put it in tea, you used the right IM technique, and you're watching the ECG. But now the real monitoring begins.
Right.
We need to talk about what happens when the dopamine blockade goes too far or when other drugs enter the mix. Let's look at the drug interactions first.
Okay, going back to the liver, we talked about CYP3A4 and CYP2D6 enzymes breaking Haldol down. So it stands to reason that if a patient takes another medication that inhibits those enzymes, the liver stops breaking the Haldol down.
Right, and then the haloperidol concentrations will spike dangerously, which drastically increases that risk of QT prolongation and extrapyramidal symptoms.
But what if they take an enzyme inducer, something that puts the liver into overdrive?
Then the liver processes the Haldol far too quickly, and the drug concentrations in the blood drop, meaning the patient loses the therapeutic effect.
Okay.
And here is one of the most fascinating and frankly terrifying interactions for a discharge planner. Tobacco.
Wait, tobacco?
Yes, tobacco smoke acts as a potent enzyme inducer.
Wait, so a patient could be perfectly stable in the psych ward, which is usually a non-smoking environment, but the minute they go home and light up a cigarette, they start hallucinating again because their liver speeds up.
That is exactly what happens. Heavy smoking induces the enzymes, the haloperidol levels plummet, and the patient experiences a severe relapse of their psychotic symptoms.
That is wild.
It is a massive variable that clinicians often miss.
You just don't typically think of a cigarette as a direct drug interaction modifying liver clearance?
No, you really don't.
Okay, let's move from interactions to the side effects. We mentioned the extrapyramidal symptoms, the EPS. I always visualize EPS like a puppet with tangled strings. The brain is trying to send these smooth movement signals down to the muscles, but the dopamine blockade just tangles the strings up.
That's a great mechanical analogy. The strings get crossed. EPS includes 3 main presentations. First is akathisia, which is a severe, almost torturous inner restlessness.
Like they can't stop pacing.
The patient literally cannot stop pacing or shifting. Second is dystonia, which are severe, painful muscle spasms, often locking up the neck, jaw, or eyes.
Ouch.
Yeah. And third is pseudo-Parkinsonism, which includes the resting tremors and the rigid shuffling gait.
And those are common, distressing side effects, along with milder things like drowsiness, headache, and xerostomia, which is dry mouth.
Right.
But if I'm at the bedside doing my rounds, what specific findings mean I need to call the provider immediately? What is the drop everything emergency?
The absolute biggest red flag is neuroleptic malignant syndrome, or NMS. This is a life-threatening, multi-system reaction.
Then let's explain the why here. Dopamine doesn't just control movement and reward, it also acts as a regulatory brake in the hypothalamus.
The body's internal thermostat.
Right. So if Haldol slams on those dopamine brakes entirely, the thermostat breaks.
Exactly. The result is massive hyperthermia, a fever that can spike to 104 or 105 degrees very rapidly.
Wow.
Simultaneously, you get severe muscle rigidity, often described clinically as lead pipe rigidity. The muscles lock up so intensely that they begin to break down, releasing myoglobin into the blood, which then destroys the kidneys.
So if my patient on Haldol suddenly spikes a fever, starts sweating profusely, and goes completely stiff, that is NMS, and it is a medical emergency.
Yes. Stop the drug immediately and notify the provider.
Okay.
The second red flag is the cardiac threat we discussed, watching the ECG for that QT prolongation that heralds torsade de pointe. The third is tardive dyskinesia, or TD.
And what does TD look like?
These are involuntary, repetitive movements, most often seen in the face and tongue. Think constant lip smacking or tongue darting.
And the scary thing about TD is that, unlike the other EPS symptoms, tardive dyskinesia can become permanent and irreversible, even if you stop the medication.
It can, yeah.
So spotting those early tiny movements is just critical.
Finally, though less common, you must watch for new onset seizures, as Haldol lowers the seizure threshold, and also a granulocytosis, which is a dangerous sudden drop in infection-fighting white blood cells.
Okay, so recognizing adverse effects quickly is vital. But knowing exactly who should never get this drug in the first place is the ultimate preventative measure. We really need to talk about the black box warning.
The FDA black box warning for haloperidol is stark. Geriatric patients with dementia-related psychosis who are treated with antipsychotic drugs are at an increased risk of death.
That's a massive warning.
It is. These deaths typically result from cardiovascular events like heart failure or sudden death, or from infections, predominantly pneumonia. Furthermore, there is a distinctly increased incidence of cerebrovascular adverse events.
Meaning strokes and transient ischemic attacks.
Correct.
Okay, I have to point out a glaring clinical contradiction here. We just discussed a few minutes ago that a common off-label use in the hospital is for severe behavioral and psychological symptoms of dementia.
Right.
But there's a literal black box warning against using it in that exact population because it increases stroke and mortality risk. How does a clinician reconcile that?
It's the ultimate tightrope walk in geriatrics. It basically comes down to a highly regulated risk versus benefit analysis governed by federal law.
Federal law.
Yeah. Specifically, the Omnibus Budget Reconciliation Act, or OBRA, heavily regulates antipsychotic use in long-term care facilities. You cannot just prescribe Haldol because a dementia patient is pacing the halls or being mildly uncooperative with hygiene.
It has to be an extreme scenario.
Exactly. OBRA dictates it should only be initiated if the patient is a substantial danger to themselves or others, or if they have distinct distressing symptoms of severe mania or psychosis.
So it's a last resort.
It is a last resort. Furthermore, if the condition persists beyond 7 days, the facility must document that non-pharmacologic interventions were attempted first, and they are legally required to attempt a gradual dose reduction, or GDR, in 2 separate quarters within the first year. They are actively trying to wean the patient off the drug entirely.
So it is never a casual prescription. It is highly monitored. And speaking of monitoring, what about patient education? What are we teaching the patient who is taking this medication at home?
The education is straightforward but crucial. First, advise them to take oral doses with food or a full glass of water to minimize gastrointestinal irritation. Okay. Second, hammer home the point about the liquid concentrate. Remind them never to mix it with coffee or tea because of that precipitation reaction.
And they need to know the red flags, obviously.
Well, absolutely. They need to seek emergency medical help immediately if they develop severe muscle stiffness or a high fever, the signs of NMS.
Right.
They need to report any abnormal involuntary movements of their face or tongue, which are the early signs of tardive dyskinesia. And they must report sudden severe dizziness, palpitations, or fainting, which could indicate that their heart rhythm is being affected.
All right. It is time to go all home. We've navigated the brain pathways, the liver enzymes, the oil-based injectables, and the federal warnings.
You've covered a lot.
We have. Let's consolidate everything we've discussed into the ultimate rapid-fire review for clinical practice and board exams.
Let's do it. Here is your must-know priority. Haldol is a high-potency, first-generation antipsychotic that works primarily by blocking dopamine. Because of this, you must watch the ECG for QT prolongation and torsades de pointe, especially if it is administered intravenously in an emergency setting.
Excellent, and you're nice to know details. Tobacco use actually decreases the drug levels in the blood due to hepatic enzyme induction, which can cause a sudden relapse in symptoms. Plus, because of its highly specific receptor profile, it has lower risks of orthostatic hypotension and severe sedation compared to older antipsychotics.
For your exams, here is the classic test trap. Formulation confusion. Do not confuse haloperidol lactate, which is immediate release, aqueous, and can be given IV off-label or IM with haloperidol decanoate, which is a long-acting depot injection in sesame oil that must be given deep IM only.
And remember the chemistry trick. Never mix the oral concentrate with coffee or tea.
The clinical red flags you can never miss. Watch closely for neuroleptic malignant syndrome. Look for that sudden high fever and lead pipe muscle rigidity. And always remember the black box warning for increased mortality and stroke risk in elderly patients with dementia.
Finally, to tie the entire mechanism and the clinical warnings together, let's build a one-sentence memory hook. How about? Haldol halts hallucinations by dropping dopamine, but watch the heart, the elderly, and the extrapyramidal symptoms.
That's perfect. Haldol halts hallucinations by dropping dopamine, but watch the heart, the elderly, and the extrapyramidal symptoms.
That hits every single priority.
Before we wrap up our analysis today, I actually want to leave you with one final fascinating detail buried deep in the pharmacology profile.
Oh, lay on us.
We've talked for the last 15 minutes about Haldol blocking receptors, treating it like a static shield on a door. But antipsychotics like Haldol actually have profound neuroplastic effects.
Wait, meaning they physically change the architecture of the brain over time?
Yes. They induce synaptic plasticity, which is the physical remodeling of synapses, and neurogenesis, the actual development of new neurons.
Yeah, that's incredible.
This happens specifically in the striatum, where those D2 receptors are most heavily concentrated. This physical remodeling takes weeks, which explains why some of the deeper therapeutic effects of antipsychotics don't happen overnight, even though the dopamine is blocked immediately.
So we aren't just temporarily turning down the dopamine volume. We are literally watching the medication remodel the physical cellular architecture of the patient's brain while they take it.
It completely shifts how you view the weight of administering this medication, doesn't it?
It really does. It demands that respect we talked about at the very beginning. Well, thank you for taking this clinical deep dive with us today. Whether you are walking into a board exam, doing discharge planning, or walking onto the floor for your next critical care shift, we hope you carry these insights with you. Remember, the clinical landscape might be murky, but when you understand the why behind the medication, you can navigate those muddy waters safely.